week as a speaker. He's also giving a dinner the night before, so you will get an invitation and you can attend. Even though, frankly, it's a pharma-sponsored dinner, I think it should be an open conversation, so it should be an enjoyable evening. Today we've got 2 and potentially 3 speakers, if we have time for a third. Jimmy Nolin, who's working in Thiel's laboratory, is going to talk about Phospholipase A2, Group X, and allergic airway disease. I don't know what Group X is, but I presume he'll tell us. And Dan Petroni is going to tell us about what he's been doing in his second year of fellowship. Dan, you want to start?
Starting out good because I haven't gotten the shock dose computer yet. All right. So, hello everybody. Good morning. So here are my topics that I'm going to talk about today. So 2 of the big areas that I've been studying is drug allergy and food allergy. So first start talking a little bit about the cystic fibrosis project I've been working with Drew on, as well as I just had a meeting about this, the new Desensitization challenge set up at drugs at Seattle Children's. Food allergy, an update on my Gemini project and some of the new labs that I helped create over at UW. So worldwide, adverse drug reactions may affect up to 10% of the world's population and affect up to 20% of hospitalized patients. And our worldwide drugs may be responsible for up to 20% of fatalities due to anaphylaxis from the WHO. And so cystic fibrosis, for those of you who don't recall this disease, I saw a lot of this as a pediatric resident. Most common recessively inherited genetic disease in Caucasians, characterized by the buildup of thick, sticky mucus, particularly in the respiratory and GI tract. And for those of you who are of an older generation, this was considered really a fatal disease in childhood. But nowadays, with treatment, these guys are living into their 30s and 40s. Yeah, not just a kid disease anymore. So, just as a reminder, it is a defect of the CFTR protein, which is a transporter for chloride. And so either lack thereof, which is the most common delta 508 mutation, or defect in the actual transport prevents the excretion of chloride, which causes the buildup of this thick, sticky mucus, which causes all the problems in CF, both in the pancreas as well as in the respiratory tract, leading to lots and lots of problems. So in the CF population, the most significant contributor to morbidity and mortality is related to chronic suppurative lung disease. And due to the development of resistant strains of bacteria, you can imagine these guys are getting exposed to a tremendous amount of antibiotics throughout their entire lives. The choice of antibiotics often becomes limited, particularly in the adult population, especially when they get into their second and third decade of life. And then colonization of multi-drug resistant strains of bacteria directly correlates with worsening clinical outcomes for CF patients and ultimately their death. So there was an initiative started a couple of years ago between UW Allergy and UW the Cystic Fibrosis Clinic, and patients were referred if a patient reported antibiotic allergy lists, which became so extensive that it compromised their management. Here's one example of one such patient. This is from their allergy list from EPIC. Has allergies to cefepime, ceftaz, cipro, meropenem, ofloxacin, sulfa, tetracycline-zocin. Imagine treating this person for something, if anything. I don't know what drug you could necessarily use in this person. And so this person was very much sent over because sort this out. What can we do better? So cystic fibrosis and drug allergy. Several studies over the years have studied and examined the incidence of drug allergy to beta-lactams in the CF population and found it to be upwards of 3 times the general population, on average about 29%. Okay? With the push for home antibiotic infusions, so in the pediatric world, we admit these kids and we throw tons of antibiotics with them. We do CF tune-ups. But in the adult population, they have turned away from that. So all these people are getting these CF patients are getting their infusions at home. And many of these antibiotic allergies happen away from medical supervision. They just say that they're having these issues, and then when they call up on the phone, you're like, okay, put it on your list, and therefore it's gone. And then in this era of EMR, once it goes on your antibiotic allergy list or allergy list, it's automatically restricted. Flags pop up everywhere. It says, "Are you sure you want to do this?" "Oh no, I don't want to do that." And so they automatically go, regardless of what actually happened.
Is that where that 29% comes from? Is that just self-reporting, or is that confirmed?
We'll talk about that in a moment. So antibiotics and CF, classically in CF Pseudomonas and Staph aureus are the two most common diseases causing infection. But more recently, B. cepaceae and Stenotrophomonas are colonizing these patients. Stenotrophomonas is a dirt bacteria. It is awfully resistant to everything. A lot of these, I've seen a lot of these kind of highly resistant bacteria coming in from like the Middle East. So soldiers coming back and then colonizing areas in the hospital, and then CF patients, other patients picking these bugs up. Antibiotics utilized in cystic fibrosis include many of the typical anti-pseudomonal beta-lactams, third and fourth generation cephalosporins, but more recently, non-beta-lactams, including glycosides, fluoroquinolones, and colicin, are increasingly used in CF patients, stuff we don't typically use in non-CF patients. So several studies that analyze the antibiotic adverse drug reactions in CF, but the majority of these studies, as your point, Len, was used patient reports and EMR allergy lists used as these to extrapolate these numbers. I don't know how it is in a lot of clinics, but usually the person who's filling out the allergy list is usually the MA or the lowest trained person, and they just say, "I have this," and they just put whatever. They put it on there. Only one European study in a small number of patients conducted a thorough allergy evaluation of beta-lactam antibiotics in their CF population, but no studies have done a thorough allergy evaluation of non-beta-lactam antibiotics in the CF population. So the purpose of our study was aimed to establish and approach the evaluation of antibiotic allergy in the cystic fibrosis population. Secondarily, we're going to use this approach to study the true incidence of type 1 hypersensitivity to antibiotics in our cohort of CF patients. So the kind of the hypothesis and the global purpose of this is that the improper diagnosis of, quote, antibiotic allergy is a significant hindrance in the management of CF patients and often leads to the use of drugs that are less efficacious, more expensive, and with the greater risk of more side effects. So here's the demographics from our small little study. Total subjects were 17, 5 males. Mean age evaluation, this is interesting, 34 years old. So these are the older CF patients. Mean lung function, FEV1, 49%, FVC of 62%. This is what stops people from kind of challenging or doing stuff to these CF patients. It's because of these numbers. Out of curiosity, who here is comfortable challenging people with like FEVs in the 30s and 40s? Antibiotics. Yeah. So average number of antibiotic allergies in each of these patients, 3. So how we did it. So patients with CF and medication allergies that were interfering with their medical care were referred by a pulmonologist to UW Allergy. Patients underwent a thorough drug allergy history, which is oftentimes the first time this has ever happened. Spirometry, and then antibiotic skin testing if there's stuff available for it. If testing was negative and our history was not consistent with the severe drug reaction, and the antibiotic was critical for their medical care, then the patient underwent a challenge to this antibiotic to rule out a true type 1 hypersensitivity. So here's the skin testing that we use. So we use both the standardized pre-pen as well as non-irritating versions of all the other antibiotics we have listed there. This was collated from our own experience as well as from the literature as well. So there's no positive or negative predictive value for the non-standardized ones, but they were just used to kind of risk assess the patient. If there was any, like just because it was negative doesn't mean we say it's all clear. It's just that if it was positive, then we're that much more concerned that this might be a real thing. The challenges. So 3 different types of challenges that we conducted. For oral antibiotics, this was done in clinic. A single full dose of antibiotic was administered in our clinic where acute care is available on site. So this is over at UW, so ICU is just upstairs and ER is really close by. And the patient is monitored for an hour. IV antibiotic challenges were done over in the infusion center, or they were conducted on the floor, depending on the circumstances. And so they were administered with 3 doses, 1 to 100th, a tenth, as well as then the full dose, with 30-minute intervals in between. Then inhale challenges were conducted in clinic with the full dose with pre and post spiros, as well as 1 hour monitoring afterwards. So a negative challenge was determined if the patient had no signs or symptoms of type 1 hypersensitivity within an hour of the full dose of antibiotic administration. And then the patients were instructed for any of the delayed type reactions to give us a call if they have any reactions within the next 72 hours. So here are the numerous antibiotics that were listed. So basically almost every single major class of medication was kind of represented in this small cohort. So here is kind of a big block of a table with all of our skin testing and challenges, and not a single person had a single positive challenge. So out of 17 total challenges, I'll go through it. Out of total of 17 total challenges that were performed, 5 oral, 11 IV, 1 inhaled, no reactions occurred. One patient had mild itching within a day post-infusion and was treated with a single dose of cetirizine and had a complete resolution. There were no other delayed reactions. Only 2 patients with 2 antibiotics had histories that were consistent with type 1 hypersensitivities. These guys were pretty severe. They had FEV ones, I think, in the 20s. So they were pretty bad, and their reactions were documented in the EMR, and so we knew that this was a real thing. So there was no reason to even challenge these guys or to challenge or skin test or do anything. We said if they need it, desense them. Okay.
It would have been interesting though to at least skin test those 2 people. I mean, there'd be no risk in that. See if even with a history that strong, there's any value in cephalosporin skin testing.
Sure. But it wouldn't have changed our management either way. So even if it was negative, we wouldn't have done anything. So remember that patient that I talked about with all those antibiotics. So going through their list. The Zosyn, pre-PED negative, challenged with the MOX. Zosyn at the next inpatient, no issues. Cefepime was, skin test was negative, IV challenge passed. Ceftaz negative, skin test, IV challenge passed. Miro negative, skin test, IV challenge passed. Cipro wasn't done. Her reaction to Cipro was that it made her manic depressive. So we didn't even see that in clinic. But it was only done if she needed the medication in the future. Most of her bugs were actually had resistance to the fluoxetine, so there was really no reason to challenge her. Bactrim, she passed an oral challenge to Bactrim, and tetracycline, again, similar to Cipro. Not done unless it was needed in the future. So you can see just from our kind of what we did for this patient, just kind of opened up basically the entire pharmacy to her for her treatments. Okay, so we came up with this kind of schema for how to approach this. So with the suspected antibiotic reaction, if there was any sort of severe cutaneous reaction, Stevens-Johnson's, TN, dress, then no challenges, use alternative medication, period. If the reaction was very soon after the infusion and is consistent with the type 1 hypersensitivity, we've advised to avoid that medication class. But if there's nothing reasonable, to then send them over to us to test and then to challenge if needed. This is kind of like how we approach this. And notice that I have no criteria. There was no necessary criteria for what their FEV1 is, et cetera. Mainly because a lot of these times they're coming down to the last 1 or 2 antibiotics that they need, and they really need it. So, all right. So ultimately, the goal of this evaluation is to classify each adverse drug reaction to 3 categories: clear to administer, recommend rapid drug descents, and antibiotic needs to be strictly avoided, and we talked about that in the chart. So utilizing our approach to assess antibiotic allergy, preliminary. So this is not that many patients. There's only 17 patients. That true type 1 hypersensitive antibiotics may be overestimated. Okay? So out of the 17 patients evaluated, with a total of 51 suspected antibiotic reactions, only 2 out of those 51 antibiotics were proved consistent or had a history consistent with severe type 1 reactions. So a total of 49 antibiotics out of for 17 individuals, 49 antibiotics were removed from their allergy list and to be used for their treatment. So next steps. So in order to have a better idea what the true incidence of type 1 hypersensitivity and to see if our preliminary kind of observation is true, is we need far more patients. This is ongoing. We're seeing these patients once or twice a month and consistently kind of doing this workup on them. A wider variety of patients also need to be evaluated as well. For the most part, these patients, CF patients, were of the more severe type, based on, because the only guys we would really do this for are the ones where this is a major issue. So, like if somebody had a 49% and they had just one antibiotic and it wasn't really affecting their CF care, there's no reason to put them at risk. But it's the ones who had the numerous drug allergies, then we would say that it's appropriate to challenge these type of patients. So conclusions. So drug allergies, cystic fibrosis, even with below FEV1, skin testing and drug challenges can be done in the appropriate setting. And I think regular clinics are not necessarily the appropriate setting, but somewhere in a hospital-based clinic would be the most appropriate setting. And drug challenges can be utilized in this way to kind of eliminate drugs from their allergy list. And any questions about this part? So this is a paper that Drew and I are going to be publishing hopefully soon.
I mean, just taking a good history, you could probably clean up 90% of it.
Yeah.
Just by sitting down and, as you point out, I mean, the word allergy is used
for everything.
Yeah, what allergy means to the public is anything in life, in any way it bothers me.
Precisely.
When you talk about the side effects from your standpoint, they had a study that was published in one of the journals about Kaiser doing this in Portland, and they took allergists, everybody who came in with a penicillin allergy history. They didn't do any other drugs. Instead of admitting them with that history, they made an allergist evaluate all of them when they came in the hospital. And if you go into the hospital with the diagnosis of penicillin allergy, your length of stay is at least 3/4 of a day longer. Your cost of care is 30 to 40% higher. And your chances of coming out with C. diff or vancomycin-resistant enterococcus or something else is dramatically different. So they figured it cost them $600,000 to evaluate all these patients and take away their drug history. And they estimate they saved $60 million on the cost of care. So I think it's not just the CF people. I mean, this whole thing, their incidence is 1% of the people who think they're really allergic, they end up finding that they're really allergic.
We've actually had talks with UW about that. It's a manpower issue at this point, but they've actually discussed that with us.
Well, our hospital team asked me if we could do that, and I said we could, but we really don't want to. It's always 12 o'clock at night that they want you to come do this. But the statistics are pretty scary. I mean, what we do to these people by giving them clindamycin and all these other drugs, we just select out for these really weird organisms, and it costs a lot of money.
Aren't you partially doing it here on the inpatient service?
For people to get, as Tree and M, we get an automatic consult to see if they have a history of penicillin allergy, and we see them if necessary. So that's kind of an indirect route that we've taken.
But just the cost was mind-boggling to me, how much difference it is in price for their hospitalizations.
I just had
the other population that would be seemed like a target would be the people with Mycobacterium avium. So you see those in pulmonary and ID, and they're typically on 3 to 4 drug antibiotic therapy for a year, and the rate of allergy or intolerance of drugs is very high. It's reportedly, the stuff from National Jewish is higher than typical drug intolerance. So people have wondered if there's something about having mycobacterium that makes you more susceptible to having these allergies. But I'd say that's a constant problem. Matter of fact, we would sometimes treat them in the pulmonary clinic, and I got fed up with that because you were constantly having to switch around their antibiotics. It's usually, ethambutol, rifampin, azithromycin plus another fourth agent initially. So, do you get referrals from those guys very often?
No, I haven't seen them.
That would be a very interesting population. So the other thing I want to talk about briefly is the new drug desensitization and challenge program that's starting at Children's Hospital. So I spearheaded this new initiative starting last year and been gone through about a year. to have a standardized drug desensitization challenge protocol available to inpatient as well as infusion center-based patients over at Seattle Children's Hospital. I just had a meeting yesterday about it, and it looks like we're probably going to be a go for this starting sometime in April, maybe March, April. One of the interesting challenges that come out through this is that we use Castle's 12 and 16-step method, which is very simple in the adult population, but if you convert that down into like a 15-kilo baby, you actually run into the problem with voluming them, and so we have to change concentrations and do a couple of things for them. So there was a lot of very interesting pharmacy as well as my PhD is in pharmacology, so there's a lot of interesting stuff on my end for this to kind of figure out how to appropriately dose these kids. So the initial we're not rolling it out for all drugs, so it's going to be initially going to be 5 drugs. So cefepime, ceftaz, ampicillin, infliximab, and rituximab, and then we're going to roll out more as we go out forward. So like I said, likely to start off in April 2015. So there's going to be a challenge portion of this too. So I made this because Seattle Children's, there's not really allergy service, and the allergy fellows are taxed as it is to get 20 million calls. So I made it so that it was very, very basic. So if the reaction occurred over 10 years ago and was mild, challenge them. If it was less than 10 years, then go to descent and then outpatient referral after that. I gave a talk to a bunch of pediatricians on Saturday, and they actually asked about IV challenges as something that they could refer to. So something we talked about yesterday a little bit as well. We set up a challenge clinic over at Children's for antibiotics, but that's something for the future. All right, so now it's time to talk about twins. Okay.
Dan, one more before you go. When you do ampicillin, you don't challenge these people with one of the beta-lactamase inhibitors like Dimentin or Zosyn instead of ampicillin?
So this is just the first ones to roll out. This is what the ID people wanted first. But yeah, Zosyn is phase 2. Zosyn, and we're going to do other like chemotherapy agents, other biologics. We're going to do basically all antibiotics, everything. It's just this is what they wanted right away. So the CF population really is what kind of dictates it. So
one other question about the
yeah.
beta-lactams. I didn't think from the Brigham, those were in there at 12 or 16 step. You have good skin testing material. If they're negative, and
yes, so somebody has to go do the skin testing over at Children's, and it has to get approved by the pharmacy at Children's. So in 5 years, we can talk about that. But yes, I completely agree. But in this case, we don't have access to it. So if you take away the skin testing, then it's... I know. I've been banging my head against the wall for a year and a half now. So twins with reported food allergies have all this done to them: thorough history, skin prick testing, graded food challenges, and we got a bunch of samples from them. So here's our current demographics. We have 13 sets of twins that we've recruited, 12 twin pairs, 1 triplet set, 6 pairs of monozygotics, 7 pairs of dizygotics. Average age is 19 years old. The only exclusion from this group were any history of cancer or chemotherapy. So the foods that we have that were positive, we have basically representative of basically everything. So we have crab and shrimp, peanuts, chickpeas, chana dal, so those were Indian twins, cashew, pecans, hazelnuts, walnuts, pistachios, almonds, as well as egg and milk. And we have 6 sets that are in food descent trials. We have 4 in the multi-food study, 1 in peanut oral immunotherapy, and 1 in the milk patch study. So we have their pre and we'll have their post as well. So here's our totals now. We have for concordance for food allergy, I have 4 monozygotics and 2 zygotics. And for discordant, I had 2 monozygotic discordant twins. I just got we just did our last one on Friday. It was twin boys, identicals, one with peanut, one without. And then 5 pairs of dizygotic. Our triplet set is interesting. One sister has shrimp allergy. Her identical sister and her fraternal sister have no food allergies. And she's, I think, crab. Older crab. She's like in her 50s, I think. And again, all this is food challenge confirmed, so they all had to react in front of me, or they had to have a allergist note that was detailed to demonstrate exactly what happened to them during their challenge. So there's possibly one coming in, discordant monozygotic twin pair coming in this next Friday, and I have another possible triplet set with young peanut allergy, and it's similar to my triplet set where the one sister has peanut allergy and her identical sister and her fraternal sister are possibly negative. I also have some interesting non-IgE mediated allergy. I have 3 sets of discordant monozygotics. So I have this one gentleman who every time he eats walnuts, his mouth breaks out in ulcers, and he did it right in front of me. I saw all the fine ulcers along his tongue and his buccal mucosa and his lingual mucosa as well. And his brother, who was right next to him, his identical brother, was happily eating walnuts without any problems. And his father was like this too. So we don't know what causes this. So this will be an interesting set to suss that out.
There are toxins in walnuts that lyse epithelial cells.
But
I don't know why one person would, I don't know.
With the same genetics, it's interesting. So, and I also have a discordant severe cutaneous delayed reaction to poison oak. One identical twin touches poison oak, entire body starts to have big ulcers. The other one touches it, no real problem whatsoever. And I also have a discordant lactose intolerance too. So identical twins. This set is interesting. Her sister has lactose intolerance, possible food allergy. She had Graves' disease and had glasses, while her other identical twin, none of that. She is completely healthy, has none of those things. So, interesting things to suss out. We're also looking at a very thorough exposure history, and something that we've newly added is looking at birth trauma and exposure to antibiotics in the first few days of life, as well as delayed introduction of colostrum. Because there's some new reports out there about colostrum exposure in the first days. It's very important for population of your gut microbiome, and if you prevent that, like the baby's taken to the NICU, which sometimes happens with these twin pairs because they tend to be on the smaller side. So oftentimes you'll see this delayed transfer over to the mom. That this is often not being done. So the data that's certainly being crunched, we're doing right now. The omics are being done right now. So the exomes and genomes are being done, and then the T cell phenotyping. So more to come. And right now, pending are the methyl seeker. So that's a epigenetic stuff, as well as microbiomics from their stool. So I'm always looking for new twins to recruit. So if you guys have any in your practice, please don't hesitate to contact me, and I'll be happy to bring them over. These 2 gentlemen are identical twins that work for NASA. One is currently up in space, and the other one is on the ground. And he's going to come back in, I think, next month for a year differences in space. So I look at epigenetics and what's changed in him since his year in space. And I have a twin coordinator here who is looking for work to do. So please send them over, especially while he's here, so I don't have to do as much work. Okay. And lastly, so something I've set up with the U are these new allergy labs. So these are new Immunocat panels that are customized specifically for Northwest allergies. We also have tryptase and total IgE. So these labs are going to be run on Mondays and Thursdays. So it should be quicker than sending it out to the national labs. And they're set up for specifically for us here in the Pacific Northwest. And let me show you our panel. So there's a limited Northwest panel. This is kind of intended for like primary care docs. And then here's the kind of extended panel that we have. All these things can be ordered individually or as a whole set. And then there's foods, as well as aspergillus hypersensitivity, and like I said, tryptase and total IgE as well.
So what's the cost?
That I knew that I told them to get that number to me. They haven't gotten back to me yet, so they're going to get back to me because I told them my very first question somebody's asking me is how much does it cost? I don't know yet, but I will get back to you. All right. That is it. Any questions about anything I talked about?
I'm going to take a little bit of a different approach here since I'm a PhD. I don't have any medical training, so this is all going to be basic science. Hopefully it's still interesting to you. My PhD training was all in redox biology and redox regulation of lung inflammation in mouse models of allergic asthma. And I've kind of transitioned into looking at lipid mediators in controlling airway inflammation and specifically type 2 inflammation, working with Teal. I'll be talking to you a little bit about this project that we've been working on. Teal had been working on for a while, and I came in and we're kind of running with it now. Looking at this phospholipase A2 group 10 and allergic airway disease. Group X sounds a little more mysterious and sexy, but
I thought it was X.
So a little bit of what I'd like to get through today is telling you a little bit about what we know about this secreted phospholipase in asthma. What happens when we knock this out in murine models, in two different models of asthma, an ova model and then a house dust mite-induced model. And also, the more interesting part for me, at least, is one of the major projects that I'm working on. We just submitted an F32 grant, a fellowship grant, looking at certain adjuvant properties of secreted phospholipase A2, endogenous phospholipase A2, and what that might be doing to drive type 2 allergy. So a little bit of background. Phospholipases and phospholipase A2s consist of several different types of subfamilies. And more, our focus is more on secreted phospholipases, or the SPLA2 group. And their main mechanism of action is to hydrolyze this fatty acid off of a lipid membrane, resulting in this free fatty acid. Typically, one form is arachidonic acid, which can be further metabolized into the effectors prostaglandins and leukotrienes, which are generally considered to be pro-inflammatory in asthma. There are some exceptions. And as another byproduct is this lysophospholipid, which some studies may have suggested can act as a potential adjuvant. So this might be a downstream consequence of this phospholipase acting as a quote-unquote adjuvant. This might be giving it adjuvant activity. It's also interesting to note that in asthmatic patients in the lavage fluid, there's also indications that there's increased phospholipase A2 activity. Now, more specifically, and this has been a primary focus of Teal's research and our lab's research, is this subgroup, SPLA2 group 10, which Teal had shown previously is abundantly expressed in the airway epithelium and also in alveolar macrophages. And it's also increased in the airways of asthmatics, shown here, SPLA2 group 10 expression in epithelial cells and also in cells from lavage fluid. So it's really highly expressed in the airway epithelium. And it's also a key mediator of cystidyl-leukotriene synthesis by various cells because it really regulates the first rate-limiting step of the free fatty acid release, which is required to form these cystidyl-leukotrienes. And we also have some potential evidence that these new innate lymphoid cells, which many of you may have heard of if you do any type of research in gut immunology or lung immunology, these cells are kind of a hot topic now. There might be some evidence that this enzyme is impacting the status of these cells. So we'll get there. So from an earlier study, this is actually some of Bill Henderson's earlier work, which looking at these group 10 deficient mice. So these mice globally lack all phospholipase A2 group 10 and all cell types. And these mice are actually protected from developing airway hyperresponsiveness in response to increasing doses of methacholine. So these mice are, for all intents and purposes, normally functioning lungs. These mice also have a decreased amount of these type 2 cytokines, IL-4, 5, and 13, which are what we usually think of as a typical Th2 or type 2 immune response. So there's some kind of impairment with these mice in developing an immune response that seems to be mostly due to an impairment in this type 2 response. Now this was in an ova model, so this is an innocuous antigen that we make mice allergic to They don't necessarily see it in the environment. They don't necessarily breathe in dried egg whites, but it's still a really nice model for looking at specific immune responses. So a while back, what a lot of the field transitioned to, and Teal and others in the Center for Lung Biology kind of came up with this protocol, is instilling house dust mite into the airways of these mice to elicit a more physiologically relevant type of immune response, where we give these mice 100 micrograms of house dust mite oropharyngally on day 0, and then 5 subsequent challenges of 25 micrograms oropharyngally, analyzing on day 21, looking at airway hyperresponsiveness, measurements of lung function, inflammatory cell influx into the airways, and also production of cytokines. And we're doing this in both wild type and the SPLA2 group 10 deficient mice. And what we notice is, looking at parameters of airway mechanics, resistance R and elastance E. If you look at these white squares, these are the knockout mice exposed to house dust mite. They show a significantly attenuated parameters of airway hyperresponsiveness in both resistance and in elastance. So these mice, again, just like what Bill Henderson had showed in the OVA model, these mice are protected from developing allergic airway disease in the house dust mite model. And we can also see that DIRP1, which is a major antigenic epitope, major antigenic protein in this house dust mite, DIRP1 specific IgE is much lower, significantly decreased in the knockout mice, and also total IgE. Because again, this is not specific to house dust mite, but this total IgE is also significantly attenuated in these mice. So these mice are displaying essentially a dampened immune response across the board, independent of OVA or HDM sensitization. Now, looking further at what's going on with the cell types in these mice, we would lavage these mice and look at the cell differentials in the lungs. So primarily looking at eosinophils, neutrophils, and CD3 positive T cells by flow. By these analyses, we can see that there are some striking differences where in both the lavage fluid and in the lung, eosinophil content is significantly decreased in response to house dust mite. There's really no difference in neutrophils, which got a little off-center here. And there is a significant difference in T cells. So there's a difference in eosinophils and T cells in these mice, which would indicate, which I guess it goes along with what we see in the decreased immune response. The neutrophils are more involved in acute or acute response. We're not really seeing a difference in here. We may be missing that time point. So this is kind of shifting gears, and I'm hoping this doesn't come too much out of left field. But like I had mentioned previously, these innate lymphoid cells that are shown in this panel here have been gaining a lot of attention, and they're still not really well understood. They were described maybe 6 or 7 years ago, and our knowledge about them is really increasing, but they're essentially a lineage negative lymphoid cell. So they're not a T cell, they're not a B cell. They express a lot of unique markers, but they also express a lot of markers found in other cells, so they're really kind of difficult to mine out. But what's really interesting is these cells are thought to be innate responders to these types of stimuli that are primed and ready to go, and they are responsive to epithelial-derived cytokines, primarily IL-33, shown here, which is significantly attenuated in group 10 deficient mice exposed to house dust mite. And they are also responsive to IL-25 and to a lesser extent another cytokine, TSLP, thymostromic lymphopoietin. And more interestingly, when we look at these mice that lack phospholipase A2 group 10, they actually have fewer of these innate lymphoid cells. And we worked pretty hard trying to optimize this gating strategy for flow to really isolate this cell population. We think we've done a pretty good job. There's some variability here, but I think you can appreciate there is a trend towards a difference. And we're also have repeated these, and they look really nice. So this is kind of hinting at the reason we're seeing these alterations in these immune responses. It may be due to this innate response that really kind of gets things going, because these ILC2s can then propagate the Th2 response. And if we're not getting this initial response, then downstream responses may not occur as robustly. So for this first part, I just wanted to get through this pretty quickly. These mice lacking this phospholipase A2 group 10 seem to be protected from developing manifestations of airway hyperresponsiveness in both an OVA and an HDM model. IgE and HDM-specific IgG is also blunted in these mice. And these mice also have significantly fewer eosinophils and T cells with no real differences in neutrophils. And there's also some evidence that these mice may have decreased ILC2s compared to wild-type cells. And this may be due in part to an epithelial impairment of the ability to produce IL-33 and other epithelial-derived cytokines.
If you don't mind, I'll just make a quick comment. Just because I don't know how familiar you all are with these different models, but the original model that Bill did with the OVA alum model is using an exogenous adjuvant. And what several studies since then have shown is that when you use that adjuvant alum, you're driving a very strong adaptive immune response. And so you get allergen-specific IgE. And in subsequent studies with like Kelly McNagny, it shows that you actually kind of bypass this innate immune response with ILC2s that seem to be extremely prominent and being kind of like the majority of the emerging information about the etiology of asthma in these kind of model systems such as house dust mite that have their own adjuvants. So what we're doing is we did it with house dust mite, which is a model which is dependent on innate cells. So innate cells then don't necessarily need to have an adaptive immune response. And so that is a major question. But what Jimmy was just showing is that the knockout is actually altering both. It's altering the generation of the innate lymphoid cells, but it's also really knocking the adaptive immune system. And so this is really one of the key things in immunology, how these innate lymphoid cells interact with the adaptive immune system, making antigen-specific cells ultimately. And so I think hopefully this study is going to be extraordinarily informative about how a natural antigen like house dust mite leads to both allergic inflammation, but also that regulation between innate cells and adaptive immune cells. So anyway, that was sort of my comment. I wasn't sure, if that sort of like that little nuance there, if it was coming across. So.
That was great.
Can I just ask a naive question?
Sure.
If this is ELA210, does that infer there are 9 others?
There are others. Like so many things, the numbering doesn't necessarily represent how many. It's not really sequential, but yeah, there are several others of the SPLA2.
Yeah, there are 10 other mammalian PLA2s. It's interestingly enough, there's also like 12, group 12, for example. So they're not. It's not like it's sequentially numbered from, 1 to 10. And there's a bunch of sub.
Why select this one to study? Why is it unique compared to the others?
That's a good question. Actually, so 2 of them have very strong phospholipase activity. It's group 5 and group 10. So in our initial study, the 2007 study, where we were looking at which of these might be relevant in human asthmas, the 3 that came up are really group 2A, which is a very ubiquitous one. Its activity is very low, and group 5, which Alan Leff and several other labs have been very interested in, we can barely detect in human airways. And then group 10 is extremely prominently present in human airways. So it seems like the most logical target. And we fortunately identified that about the same time that Bill and Mike were doing the knockout model with the group 10, so with the OVA.
The group 5 and 10 got the most attention early because they have the highest activity on arachidonic acid for releasing that from lipid phospholipids. So for people wondering for generation of prostaglandins and leukotrienes, those are the most likely ones. All the other ones are much less active for releasing arachidonate. But it's a whole, it's a vibrant field because some of them are like cobra venom phospholipases and others are pancreatic phospholipases and implicated in rheumatoid arthritis. So of the 13 mammalian secretory PLA2s, they've each got a little niche and potentially in some diseases. There's a couple that are pseudoenzymes that don't actually have any enzymatic activity, but they have specific receptors on target cells. So it may not be just biochemical properties of these secretory PLA2s, but they may be receptor interactions that are important too in cell signaling. So it's a complicated field, but the group 10 of all of them is the most active for releasing arachidonic acid. That's sort of the simplest way of thinking about it.
Have you been able to replicate the knockout with like anti-IL-33 or anti-TSLP to see if what you're saying is if it works through ILC2 if you blunt that? Because there's antibodies out there for now. I know in humans they're definitely.
Yeah, that's some of the work we're proposing. That's some of the work that's on his F32.
Yeah, like the ST2 IL-33 receptor neutralizing antibody. That's one of the things we have proposed. But more of the focus is on this model where we inject SPLA2 along with OVA instead of using alum, aluminum hydroxide as the adjuvant. Getting some pretty interesting results. All right, in the interest of time, I'll move forward. So setting up some rationale for why we care about the potential of phospholipases as adjuvants. I say that because it's not necessarily the PLA2s themselves as the adjuvants, sometimes it's their products. So this paper published in 2013 in Immunity, and I'll walk you through each panel here, essentially looked at using bee venom phospholipase A2 or melittin, and a compound that increases PLA2 expression in human populations or wherever these bees tend to sting. Turns out that bee venom given as an adjuvant along with OVA or phospholipase A2 isolated from this bee venom given along with OVA can act as efficient adjuvants to induce this type 2 response. So these are IL-4 GFP tagged cells. When these mice were further analyzed, they harvested CD4 positive T cells from the lymph nodes of these mice and re-stimulated these cells with OVA. And only in the mice in which OVA and this PLA2 were injected intraperitoneally to increase the sensitization using PLA2 as an adjuvant did they see the production of these type 2 cytokines IL-4, 5, and 13. If these mice were simply sensitized with saline and OVA, there was no response. So PLA2 essentially drives this type 2 response in this model. And then when they looked at OVA-specific IgE and IgG, they note that though there is some variability, both in bee venom and to a greater extent, the PLA2 isolated from this bee venom drives this adaptive response as well. And what they really nailed down here is that when they inject just bee venom PLA2 intraperitoneally and lavage the peritoneum, they see this rapid increase in total IL-33. And if you remember, IL-33 is an important cytokine in driving this innate lymphoid cell type 2 response. They see this start to decrease by about 2 hours. What they further show by flow is that in wild-type mice, given this B venom PLA2 just injected into the peritoneum, there is an increase in this ILC2 population, which you can believe me or not is this lab right here. And in mice that lack this IL-33 receptor, so these IL-1, RL-1 knockout mice, can't respond to IL-33, there's essentially no ILC2 response. So this group is showing that this B venom PLA2, which is a known allergen, can induce a type 2 response that is dependent upon innate lymphoid cells. So it's an innate response that also drives an adaptive response, as evidenced by the increase in IgE and IgG.
Was the amount of PLA2 physiological levels that they were able to inject, or was it super physiological?
It was higher.
How much higher?
This, I think it was 50 micrograms. Close to that.
Yeah, it's they were studying B venom anaphylaxis, and they kind of showed all this stuff in the periphery. It didn't seem like they thought at all about what we thought. That wow, this must be an explanation for how, when you give a dust mite or whatever, the PLA2 is acting as an adjuvant, maybe in the airway. But they were basically studying anaphylaxis, and if they gave a little too much of the PLA2 under the initial dose, the mice would anaphylax and die. Actually, they didn't really put it in the paper, but once we communicated with them, they told us all about this. But then the big thing is that they're doing the B venom, but then they're giving a harmless antigen with it to show that it has this adjuvant property, not just a direct anaphylaxis response, which is really interesting. And it shows that part of it shows that you're just activating the adaptive immune system with ILCs, but the interesting thing is that downstream to that also seems to be that you're activating the adaptive immune response, which is, I think, really pretty novel over the last couple of years from the immunology standpoint, that the ILCs actually could be the drivers of the adaptive immune response. So because they're antigen independent.
All right, so this paper, as Teal had mentioned, brought up some really interesting points, but they didn't really look at sensitization with PLA2 and OVA and what happens in the airways. So logically, that was one of the next steps that our group had taken, and Teal had developed this protocol prior to my arrival, where we give 100 micrograms of OVA and 50 micrograms of SPLA2 intraperitoneally on day 0 and 14, challenge oropharyngally with 100 micrograms of OVA, 26, 27, 28, and then on the final day, analyze AHR, inflammatory cell cytokines, all of our favorite markers. And the overall hypothesis of this is that we believe that this SPLA2 group 10 acts as an adjuvant, enhancing type 2 responses, primarily through release of epithelial-derived cytokines like IL-33 and also polarizing ILC2s, ultimately driving the adaptive immune response. So some of the data is very interesting. So when we first look at airway mechanics, we noticed that, first of all, this H48Q is a catalytically inactive mutant. It has a point mutation that renders this SPLA2 group 10 completely inactive. It has no phospholipase activity. So it's kind of a negative control to test whether or not it's its activity that's driving this process, or if it's just the protein potentially binding, like Bill said, to a receptor, which is another story that we could talk about. So when we look at this, using either the H48Q mutant or the SPLA2 group 10 wild-type protein, we see a robust increase in AHR. There's really no difference. If anything, it looks like the mutant may be causing slightly more of a response. But what we can say is that these proteins are inducing a hyper-responsive reaction in these mice. What's further interesting is that when we look at OVA-specific IgE and IgG responses, only in the mice that were given the wild type, fully functional SPLA2 group 10 protein do we see an actual adaptive immune response. So whatever the reason that we're seeing these similarities in AHR are masked, we're definitely seeing a difference in the adaptive immune response that's dependent upon the activity of this enzyme, which would indicate that there's something downstream of the enzyme itself that's driving this process. All right, so when we looked a little further at the differentials in the lavage fluid and in the lung, this is why we look at these two different compartments separately. Because in the lavage fluid, we see a significant attenuation with the mutant in eosinophils and T cells. And we see this really nice, robust increase, this nice, robust immune response. When we look in the lungs, there's really no difference here. So whatever's happening is definitely compartmentalized in these airways as well. And we're working on really kind of nailing that down. And this is perhaps one of the most striking pieces of data. So when we isolate single-cell lung suspensions and then do a CD45 isolation, so we're isolating essentially all the immune cells, getting rid of all epithelial cells and all structural cells. We re-stimulate these cells in culture with ova, shown in all the black bars. We see that in IL-13, IL-4, and IL-5 only in the mice that were sensitized with wild-type group 10 on the bottom do we see an immune response or a response in after stimulation of ova. And these white bars are just the negative controls. These are just saline stimulations. So essentially what this is showing is you need this catalytic activity of SPLA2 group 10 to drive this sensitization response to ova. And as I had mentioned previously, one of the byproducts of SPLA2 group 10 metabolizing and hydrolyzing phospholipids is this lysophospholipid, which the immunity paper that I just mentioned actually showed was one of the adjuvants that's driving this response. So this could explain some of the responses we're seeing in this because it's clearly dependent upon catalytic activity. So from this, we can say that this SPLA2 group 10 acts as an adjuvant, inducing airway hyperresponsiveness and ova-specific antibody production and recruitment of eosinophils and also T cells. The enzymatic activity of group 10 appears to be required for the sensitization to ova and also production of type 2 cytokines in the adaptive immune response. Group 10 deficient mice have fewer eosinophils and T cells after HCM challenge. These mice also have decreased ILC2 content compared to wild-type mice. So there's still a lot of questions to answer for this, and I just listed two. But primarily we're interested in how is SPLA2 group 10 acting as an adjuvant. We have some pretty good leads, but we'd really like to follow up with how it's actually driving this type 2 response. And more importantly, does SPLA2 group 10 induce ILC2s through epithelial release of IL-33, or is it some kind of alteration in IL-33 signaling? That we really don't know. Acknowledgements, Teal, of course, for taking me on, and Ying and Luke for doing a lot of the legwork and helping me along. Sydney, who could not be here today, and our collaborators in the Center for Lung Biology, and of course the funding. And again, thank you guys for being here today. I'll take any questions.
Kind of an unfocused question, but the paper that had to do with essentially venom anaphylaxis, does this tell us anything about those who become venom hypersensitized versus those who don't, and also the mechanism of desensitization when we treat people for venom anaphylaxis?
Yeah, I mean, I think we should turn the question around on you allergists while we're here. The data from the Palm paper, as well as our data, would suggest that if you get a bee sting, and that bee sting has birch pollen with it, and then you subsequently inhale birch pollen, you have an allergic reaction in the lung without doing anything else. That's what that data suggests.
Why would you propose that a bee sting would simultaneously give you birch pollen exposure?
The bee was the bee was hanging around in the birches.
Never thought of it that way.
Well, that's what I have to say. I mean, it doesn't seem like anyone's thinking about that, but it does. But that data suggests that if you happen to give a PLA2 or maybe a lysophospholipid, which is
antigen.
And it's in an environment with a specific antigen, that sets up an environment in which, when you're re-challenged with it, you then have both an innate response, but also an adaptive immune response to it. So,
another esoteric question on Lenington is: would you take people who have been successfully desensitized to bee sting therapy? Do their secretions of this protein, are they the same? Are they different when you try and stimulate them?
Right. Well, I mean, that's the other thing. The Palm paper showed that there was actually protective immunity that was B cell dependent. So, like, a lot of the mice anaphylaxed, and like I said, they had to back down the dose, according to the author, because the mice would die. But one of the main things is that they showed in the latter part of the paper is that, once you were sort of immunized with the bee venom PLA2, you had protective immunity to subsequent bee venom exposure. And if you took away their B cells, meaning that they weren't going to make antibodies, although they didn't further define which antibodies and so forth, then you lost that protection. So that there's two things going on. Is that maybe you're also making protective antibodies directly against the PLA2. So, and I don't know how that all works out, because when we're doing these adjuvant studies, we're of course giving an exogenous version of something that you have endogenously, so you might be less likely to make protective antibodies. But it's a complicated story, isn't it?
Well, thank you. I'm sure Jake is happy he doesn't have to go as the third speaker today, but we'll get back to you. All right, so next week we've got a visitor, Mark Riddell. And again, if you can make the dinner he's doing the evening before, you're more than welcome. Thank you.